Hi, everyone. Welcome to our weekly webinar on preventing and managing COVID-19 workplace. This is Karen Hara. I'm the Director of Marketing and Communications with WorkCare. This is our 47th consecutive week presenting the webinar, and it reminds me I posted a blog on Groundhog Day. So if you feel like it's more of the same, it is in a way, because we've been consistently presenting this webinar from week to week, but we always are changing the topics. So there's always new and interesting to learn. As you know, if you're a regular attendee, we record the session hosted on our YouTube channel and take questions via the Q&A function in Zoom. So please, during the webinar, submit questions, and we'll ask as many as we can, answer as many as we can in the time we have allowed, and we'll push answers to all questions on our website on the COVID-19 page. You can find that at workcare.com. Our speaker is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's our Chief Innovation Officer and Associate Medical Director for on-site clinical operations. Also our lead clinician for our COVID-19 response. And I think he has a great agenda for today, so I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen. And it sounds like your voice was choppy, cutting in and out, just FYI. So everybody let us know. I see the comments there. And so let us know if my voice is also choppy. We'll work on the audio connection here. But let's jump into it for today. February 3rd, we're approaching 50 programs in a row. We're excited about that. And we're excited today to jump into a topic that really is germane to what you're seeing in the news in regards to variants, and what do we do about it, right, for the workforce. So we'll dig into what these variants may represent for us and talk about some preventative strategies that are burgeoning in the clinical community in terms of recommendations. Without further ado, you know the schedule in terms of the agenda: clinical update first, followed by micro and pathology. We'll do the numbers with epidemiology and see how we're doing, US and abroad, followed by preventative trends that are happening in the both in the workplace and in the general public. And then finally, we'll end with some recommendations based upon these trends and our recommendations clinically of what we would suggest succinctly for protecting your workforce. So let's jump into the clinical update for today. Like I mentioned, we're going to talk about variants, and these variants have been prominent in the news segments for some time. And we want to make sure that we fully understand these variants. We've previously talked about these variants from a standpoint of genetic makeup and how they are produced with the spike protein mutation. We're going to dig more into the clinical impact from these variants and really understand, should we be concerned? If so, what should we be concerned about in terms of impact to our workforce? And what is the messaging that we should be sharing with our workforce in regards to protecting ourselves and our loved ones in regards to transmission prevention? So we're going to talk about relative risk. This is a definition that you may already know, but I want to make sure everyone's clear what relative risk means. In short, it's the proportionality of risk imparted as a result of looking at one group compared to another group, if we hold simply that all variables have been met in terms of making each group equal. All right. And so when we take one risk group, group A, and look at compared to all other risk groups, does that risk group A represent a higher proportion of risk for whatever outcome we're looking for, whether that be illness onset, whether that be, as in this case, death? And we want to look at the numbers in relation to 1. So if the relative risk is below 1, then there is less risk for a particular group and the variable that we're trying to understand the impact of. If it's above 1, then the relative risk is higher, or the likelihood of the outcome, whether again it be death or onset of disease, is higher in a particular group that we're examining. So today we're examining, as we mentioned, variants and the impact of variants on our community workforce, as well as transmissions. So let's dig into what the UK government and this particular group is called the New and Emerging Respiratory Virus Threat Advisory Group, right? NERV tag, is recommending in regards to impact from and what we understand about these variants. And it's important that we look at this because historically, myself included, when we look at the clinical evidence for these variants, the understanding of impact from a clinical outcome was that these variants weren't having too dramatic of an effect on severity of disease, on risk of death. There is new evidence, and that's what we're going to get into when we talk about these variants again. So when we look at the work that this body has recommended, and we look at, in particular, their summarized information and data from multiple studies, we want to examine again the impact of these variants, in particular the UK variant. That's probably the most widespread variant at this point in the US. It certainly has been the case in the UK since last year. And the nomenclature for this variant is B117. All right, and we've talked about this variant before. It has a mutation in the spike protein receptor binding site, and that's what, as well as several other mutations. But we're really concerned about what is the clinical impact from a risk of death. And what we find as we dig into this summarized evidence is that we know this variant is more easily transmitted between individuals, right? And we know that this was the main emerging variant in the UK and now in the US. And we can see several studies that look at whether or not this variant is actually increasing risk of death. This one particular case study looked at within 28 days, is there an increase from the variant? And in this case, the nomenclature here is VOC, okay? That is the variant of concern. And again, this is B117 we're talking about in these several studies compared to those individuals who were not infected with this variant. And the results were 1.5 or 1.35 relative increased risk for these individuals experiencing death within 28 days if they were infected with this particular variant. In the second study here, the number was 1.36 for the individuals that were infected with this variant. This comes from the Imperial College of London in this particular case. And they were looking specifically at the risk of death with a standardized case fatality rate methodology. All right. And so when we talk about the risk here, we know and we're starting to see evidence that the risk of death for this variant is increased. Another study listed their results as a increased mortality hazard ratio of 1.9. All right. And in conclusion, all right, should we be concerned? And the answer, flat, straightforward, is yes, right? Not only is this vector or this variant increased in its transmissibility, but also risk of death. Now, the level of concern, should it be off the charts, right, in terms of what we're going to see from an impact of mortality as a result of these infections? No, not necessarily, right? Overall, the risk of death from COVID-19 is still quite low, right? Still just above 1%, 1.8 in some cases. So we are not going to experience a huge bump in regards to the number of deaths that we see proportionally from infection with this variant. However, we should see modest increase potentially if we don't get the spread of this particular variant under control. And we'll talk about strategies to do that here moving forward. Oh, got a little aberration here with the PowerPoint. Apologies there. So let's jump into some of the pathology as we talk about these variants. We want to look at and compare these variants on a level basis of reproductive rate, right? We have looked at reproductive rate before. If you're not familiar with reproductive rate, again, it's the number of people that on average are infected by one individual with SARS-CoV-2 or COVID-19. And we know the national average is hovering around 1.2 to 1.5 in the US. In this particular study, we're looking at the variant again, and we're looking at the variant compared to its reproductive rate. In this case, this study describes it as the S gene target failure. That is the marker genetically that we want to identify the SGTF, again, S gene target failure, to understand whether or not someone has the mutation that's associated with the variant, the B117 variant. And if we look at then this study, as we dig into it, the results found evidence that the increased mean in reproductive rate occurred proportionally greater in those individuals that were infected with this specific S gene target failure mutation, i.e. the variant. And we can see then that the S gene also was associated with the increase in effect proportionally of the number of people infected with COVID-19. Put another way, we saw a shift in the number of people infected with COVID-19 having this particular mutation over time, right? And what that suggests in conclusion is that even the measures that were in place because of the increase in reproductive rate of this particular variant mutation, that the measures, in this case, NPI measures or non-pharmaceutical interventions that were implemented in the UK were not sufficient to prevent infection between September and January of this particular variant. So that suggests that additional measures are necessary to help prevent spread or transmission of this particular variant due to its increased reproductive rate or likelihood of transmission. So what does that look like graphically? Over time in this graph, we're seeing the proportion of the population, in this case in London, increase in the measure of variants in the population that were positive for COVID-19. And we're looking at this as a means of reproductive rate measurement. And we can see over time, if we go back to September, in this case, September, October, we can see where the majority of the population that were infected with COVID-19 were. This is grouping of, on the x-axis, the number of people that had the mutation, right? So on the y-axis, we're seeing the reproductive rate from 1.0 up to 1.5, and we're seeing on the x-axis, again, as we move to the right, a higher proportion of this mutation or variant in the population. And what we see over time as we move through the end of last year is an increase in the population that was positive for this variant. And we see this happen dramatically as we move into the December months, as well as obviously into January, the proportion increasing. So we know the variant is definitely a concern from a transmissibility standpoint, as well as increase in reproductive rate validated with this and other studies. So we need to talk about its impact and prevent transmission with some novel recommendations that some have been made in the popular news, but yet CDC has not endorsed. We'll get to that in a second. But let's get into the numbers from an epidemiology standpoint. We're looking at the US, where we were at 23 million, almost 24 million cases on a 7-day average, or total cases, excuse me, and a 7-day average of 62.8 2 weeks ago. Last week, we decreased that number down to 50.1 in 100,000 as we increased over the 26 million mark, and we're over 1 million on a 7-day average now. And if we look at this in a new way here, we're looking at cases in the last 7 days, not a rate per 100,000, but cases in the last 7 days. If we look at deaths, we saw where we were 2 weeks ago. at 1 death per 100,000, dropped to 0.9. And this week, we're going to look at the total number of deaths in the last 7 days, which is 22,000. Okay, and we're obviously nearing that 500,000 mark in terms of deaths, and we'll continue to watch this day over day. If we look at confirmed cases in the US, where we were 2 weeks ago, where we were last week, and where we are today, we can see that the average 7-day rolling average of daily new cases has decreased, right? And so that's good news from a holistic standpoint, but doesn't necessarily point to conclusive evidence that we're starting to get beyond the pandemic. There may be several factors that are associated with the decrease that we're seeing here, and we'll talk about that in a second. In terms of per capita per million people, we see where we stood 2 weeks ago with the UK. We add in a couple others last week, other nations to look at in comparison with Spain and Portugal, and we can see where we stand today with regard to our running second to Spain, in front of still UK and France, with regard to confirmed per million in a 7-day rolling average. If we look at deaths, obviously we have the highest number. We also 2 weeks ago saw that number increase, and we're kind of hovering still, oscillating up and down a little bit around the 3,000 on a 7-day rolling average in terms of deaths daily. The UK deaths per million still far higher than we are per capita. Germany's above us, and they continue to be so. Last week, as well as this week, we did kind of trade spots a bit with Germany, and we're still behind the UK per capita in terms of deaths. Jumping to tests, now we're going to look at and ask the question around the decrease in cases that we saw trending over the last couple weeks. We also are seeing a decrease in the number of tests. So where we were 2 weeks ago, where we were last week, and where we are today, I mean, we're not increasing the number of tests. And we know this may be a factor in regards to understanding the true number of people that are infected. So as we see this number decrease, we are concerned that the number of cases is not an accurate picture, right? And if we look at then tests per 1,000 people, we can see that we're still quite a bit of ways far behind our neighbors in the UK, Portugal, Spain, and France. And we're decreasing in that over the last week and this week. So we'll continue to watch this, but really try to understand why the numbers are trending the way they are. If we look at total positive or percentage positive tests, we over the 7-day rolling average, where we stood last week with regard to being behind, or not being behind, excuse me, where we stood in regards to Germany, where we stood 2 weeks ago, where we stood last week, and then where we stand today. We're still in a position where we're not really understanding, the full impact. We were trending up, and now we're kind of trending down in positives. So that is a good indication that we're heading in the right direction if this continues to trend downward, right? From a vaccination standpoint, as we watch these numbers week to week, we were at 31 million distributed doses, about half of them being administered. Increased that to 44, but still around half being administered last week. And if we look at this week, we're at that 52 million mark and 32 million being administered. And we saw this number earlier this week get that gap close a bit. And that spoke to a bit of the supply issue that we have now in the US, not just logistics and administration. So we've seen recently the announcements between Sanofi and Pfizer with bottling millions of the vaccine doses and increasing local supplies as well in various countries. We know that there are several approvals that hopefully will happen this month, from J&J to other contenders with regard to the vaccine. But we'll see if that's going to help our supply shortages that we are seeing play out more and more across the US. Only 6 million people have received both doses. Now, think of this in relation, we'll talk about this in relation to herd immunity and trying to estimate our progression towards herd immunity. Identifying the vaccine doses administered on a global standpoint, obviously we are doing okay from a total number standpoint. From week to week, we're still above the 1.2 million mark. But again, when we talk about per 100 people, we're not number one. UAE has been number one. United Kingdom overtook us last week and is still ahead of us in terms of per 100 people with administration of vaccines. So we'll watch this and see if our neighbors catch up to us, or if we can accelerate our administration and overcome the supply bottlenecks that we're identifying. Now, in particular, we want to look at this number from a standpoint of herd immunity. Okay, if you recall, if we're talking about an R naught or reproductive rate of about 1.5, 1.2 to 1.5, 60% of the US population would have to be either vaccinated or have recovered from COVID-19 and have natural immunity. 60% means that, point, again, if we're looking at this number here, right? I mean, 60 out of 100 people need to be vaccinated or immune. 60, right? Right now, we're looking at this chart. We're not even at one person per 100 people, right? And we got to get to 60 if we're talking just vaccination. So we have quite a ways to go to reach a herd immunity level and get on the other side of this pandemic. And hopefully, in time, we'll be able to compare the number of people infected and recovered from COVID-19 over time with the number of people being vaccinated and see where the convergence of those numbers are in regards to achieving herd immunity, both from natural and acquired immunity here in the US. So let's talk about trends from a preventative standpoint. What are the things that are happening that we need to know about? CDC recommendations regarding face mask wearing in regards to transportation is something that Biden has now put in place in this last week. Okay, so it kind of reinforces the mask wearing requirements for travelers in the US on public transportation, something that we've seen play out in cities and municipalities, but codified, excuse me, through Biden's executive order recently. And as we talk about then the topic of mask wearing, let's get a little deeper into what CDC recommends, what Tony Fauci has said recently in regards to whether or not we need to be recommending double masking to help prevent transmission. And if we're talking about the increased likelihood of transmission due to the nature of the variants that we're seeing, both the B117 variant from the UK, the variant from South Africa, and the variant from Brazil, they all have been shown to be more easily transmissible, right? And we'll see how it plays out with the other two variants in regards to increased risk of death. But it is likely that we'll continue to see stronger recommendations come out in regards to double masking. So let's talk about that a little bit more as we talk about Tony Fauci's comments. Physical coverings with one layer, it makes sense to, if you put on another layer, that it would be more effective, Tony says. That reason, the reason why you see people doing that and or recommending an N95 is to help prevent both the wearer as well as the individuals around them, right? We won't show it here necessarily in terms of the numbers and the studies in interest of time, but there are studies that are now ongoing looking at the effectiveness of a double layer. And if we talk about this double layer and look at recommendations from municipalities, in this case, let's zero in on San Francisco Department of Public Health. They have said specifically, outside of the context of N95 respirators, wearing a second mask may offer better protection to the wearer and those around them, right? And the first mask, particularly if the first mask helps improve the fit, if the outer mask helps improve the fit of the first mask being worn to minimize gapping. Furthermore, if these materials are different, that variants in materials may help capture more viral particles in this technique or this phenomenon called the Swiss cheese model of protection, right? And so again, intuitively, This makes sense. It's being proven out as we look at the emergence of data around double masking. We haven't yet seen any peer-reviewed published articles on double masking, but nonetheless, we likely will see that play out here in the next couple weeks. We want to, though, take into account that people can wear the masks properly and can wear the masks improperly. What's not suggested is that you put on a cloth mask and an N95 over that, or putting on a cloth mask, then a surgical mask. The alternative in the proper double masking technique is to don the surgical mask and then the cloth mask over that. And in some cases, the protective factor, if you look at a cloth mask being 50% effective at capturing droplets, and you layer on an additional mask that's also 50% protective, now we're looking at a 75% protective factor for use of both masks. Okay. And so, again, that increase in protective factor for the wearer in particular is something that, again, we think will be more of a recommendation, not just from local municipalities and public health departments, but hopefully eventually from the CDC. If we look at then really understanding the vaccination recommendation trends that we're seeing this week as well, the federal government has said they're going to start distributing doses directly to pharmacies, right? And this is going to help bolster access for those in underserved communities as well as broadly the general public. And this effort is going to happen in every state, most likely, and we'll hopefully see then greater access, greater distribution, and administration. And we can make some recommendations directly from WorkCare as a result of efforts that we've been moving forward with in similar regard. And so when we talk about preventative program recommendations, if you are in states that have some of the highest transmission rates, particularly with the new variants, we want you to make specific recommendations to your workforce and at least consider it. And what are we talking about in terms of states? Vermont, Hawaii, Virginia, Mississippi, New Hampshire, Oklahoma, Delaware, Florida. These are representative R0s, or reproductive rates, and the fastest represent the fastest spread of COVID-19 as of this week. Okay. And so if you have facilities in these states, do consider two things. One, making a recommendation of double masking or N95 or KN95 like masks. And if you make it voluntary, not mandatory necessarily to wear an N95 or KN95, you may be able to avoid having to fit test your workers, still educating them on the proper use of those respirators, but again, not requiring them would then help the program be scalable because we know there are bottlenecks around training mass number of workers and doing fit testing for mass number of workers for N95 mandatory use, as we have had happen in the healthcare industry. The second consideration then is surveillance testing. We've talked about pool testing previously. We would suggest if you are in these states with the fastest spread of COVID-19 to make sure you have a program or solution in place that allows you to do surveillance testing, meaning asymptomatic testing on a routine basis. If you live in certain states and counties, you have to do or provide surveillance testing, like in California, several counties in California. Right. So these are options that are on the table now and can be provided in partnership with your local provider or WorkCare if you are one of our clients or look to be one. And when we're talking about vaccinations now, WorkCare has partnered in our program for vaccinations with the fourth largest pharmacy network in the US. And when we're talking about vaccine acquisition, we're able to now provide access to vaccines in the majority of states through this network of pharmacies. All right. And vaccine logistics is also helped with this network of pharmacies in regards to access to your employees directly. And they also will be able to leverage our recommendations on identifying which location is best for them, best for your workforce. And then finally, administration becomes straightforward in one of two ways. Either they can be administered directly from the pharmacy, if that's the pathway that's the quickest for your workforce, or alternatively, as we have with some employers that are getting direct access to vaccines from state distributions, work care can then play a role in helping administer at a chosen site, or if we use alternative locations, we can have boots on the ground in that scenario. So there are positive trends from a regulatory standpoint that has allowed us to leverage this pathway. Obviously, we'll continue to see state to state processes play out in regards to access to the general public as we move beyond, move well into 1B and well beyond 1B level of distribution of vaccine and administration. And we'll continue to provide recommendations as we have new strains of the virus popping up, not new strains, apologies, new variants. New strains is a different category altogether, but new variants of the virus popping up here. We'll continue to make recommendations to help keep your workforce safe. So let's stop there. Let's open up the questions. Thank you, everyone.
Hi, it's Karen. Can everybody hear me okay?
Yeah, Karen, we can hear you.
Okay, great. Just checking. If I start to break up, just let me know, and Alexis can question. So we received by email, so I'm going to do those first because they came in early. The first question is, what happened to all of the treatments for people who contracted early stage COVID, for example, Regeneron and the other antibody cocktails? You never seem to hear about success treatments anymore.
Okay, unfortunately, Karen, you were breaking up a bit, but I think I heard the majority of that question. It was in regards to what are the efficacious treatments at this point for COVID-19 in hospital, most likely is what the question's asking, correct?
Correct.
Okay, got it.
Yes.
So the treatments have not been tremendously different than what we've seen play out previously. If you are admitted to the hospital, the majority of people are not, for COVID-19 with likely respiratory symptomatology, you're going to receive, in most cases, a steroid, a dexamethasone, right? And you're going to also receive an antiviral medication. And if you are on and require supplement of oxygen, one of the treatments we've seen play out well is convalescent plasma, as well as the monoclonal antibody cocktails that have been approved for SARS-CoV-2 in hospital treatment. And so we can do a recap of these treatments, certainly in this venue, and let's look at that for next week. But again, there has not been any tremendous leaps in treatment because these treatments that have been approved seem to be working fairly well in regards to helping those who have been hospitalized recover.
Okay. The question is, what is the new COVID symptom, COVID?
Say that one more time. It was breaking up again, Karen.
COVID tongue is a new symptom. Can you describe that?
COVID tongue?
Yes.
Got it. No, so COVID tongue likely is associated with the inflammatory process that we see from viral syndromes. Viral syndromes can cause swelling of the tongue, and in this case, likely attributed to, again, the inflammatory response that happens from a viral infection normally. So we can dig a little deeper into what's the underlying pathology, but again, in the same way in which you can have a rash or urticarial response from a viral infection, so too can you have symptoms associated with tongue swelling, tongue rash.
Okay, I think I'm going to let Alice ask the questions because her audio is a lot better, so I'm turning it over to her.
Okay, thank you.
Hi, Dr. Harris. Hi, everyone. Okay, so the next question, someone asked about a new technology called Clean Air Curtain. And from the website, it looks like it's a curtain that draws contaminated air through HEPA filter. It captures the air and then puts a curtain of air to block any additional particles and aerosols that might be lingering in the atmosphere. Is that a technology that you've heard of or are familiar with?
Yes, this technology falls under the clean air curtain, falls under a group of technologies for HVAC, not so much innovations, but HVAC solutions to help purify air locally in a building or a room. Okay. And we have seen recommendations and utilization of these type of solutions with our employers from time to time. And we don't have any long-term data or any substantial objective data as to its effectiveness at decreasing transmissions in the workplace. However, we know that these solutions, if they're employing HEPA filters, can decrease the particle load of the ambient air in a enclosed space, which would then likely lead to a decrease in risk for transmission. But again, objectively so, we haven't seen any peer-reviewed data yet endorsing a particular technique or a particular product outside of it being HEPA filtration.
Okay, the next question, in the recent guidelines from OSHA issued January 29th, they emphasized that evacuation and ventilation of areas where a positive case was worked. Does that still make sense based on the science we know now?
Can you repeat the beginning of that question again, just to make sure I heard it correctly?
Yeah, in the recent guidelines from OSHA, so issued January 29th, OSHA emphasized evacuation and ventilation of areas where a positive case is being worked. Does that still make sense based off of the science we know now?
Sure, it does in regards to it can't hurt, right? When we're talking about exchange of air, we know that exchanging the air 6 times an hour can be protective for those individuals entering that space, right? From a transmission standpoint. So in this case, if you have a positive case and you are by this recommendation required to flush or to purge the air, it would stand that this would decrease the viral count in the air sufficiently to help decrease risk of transmission.
Okay. Are the Moderna and or Pfizer vaccine effective for extended periods of time, or will the vaccine be something we'll need to get each year moving forward, like the flu vaccine?
The common clinical knowledge and wisdom right now is that it will be a requirement for year over year, and much like we do with the flu vaccine, to get your COVID vaccination. And that's going to be largely due to genetic shifts and genetic drifts of the virus itself and the need to have an appropriate vaccine to prevent transmission or prevent the virus from entering our cells with that spike protein. So at this time, it likely will be a seasonal approach to prevention with COVID, at least for the next 5 years, if we listen to some clinical guidance.
Okay. What do we know about reinfection due to variants, especially within 90 days of initial infection?
We don't know much, unfortunately. We're not seeing an overwhelming number of people getting reinfected, period, particularly reinfected within 90 days. But we do know that reinfection can occur. So we'll continue to see a collection of objective data over time. But again, at this point, there is no recommendation that would open up the opportunity for someone to be quarantined in that 90-day window as a result of a variant in the population.
Okay, we're almost out of time, so we'll do just a few more questions. How can testing be increased for asymptomatic individuals? Are they being denied testing because they have no symptoms, or are they also, a big risk?
Sure, asymptomatic transmission does represent a substantial risk as it can represent in many geographics up to 65% of cases. And so the means to help prevent transmission in these scenarios is the surveillance testing that we spoke of over the last couple weeks, and that's the pool testing access that we currently have at WorkCare that we're deploying with employers just for this purpose, right? To help identify those asymptomatic individuals and keep them home safely, quarantined or isolated until their asymptomatic infection, has resolved. And the bending the cost curve with a pool testing methodology, where the cost is not over $100, but as little as $30, is perhaps the most efficacious way from a PCR testing standpoint to do broad scale testing for asymptomatic populations.
Okay, we'll do one more question. Let's see. The World Health Organization recently announced inaccuracy of the PCR test and suggested thresholds should be lowered. The individual asking suspects this is why we're seeing downward trend of positive cases. Do you have any thoughts on this?
No, not in particular in regards to why there would be increased variability in the accuracy of PCR beyond what we've already understood to be present, right? We know that just because it's a PCR test does not make it on par with high accuracy. And so it's still a case by case examination of what test is being conducted, what assay, and under what circumstance. Again, we know that even the same assay may have variability between labs based upon that laboratory's ability to execute the tests and do so with little error. So there is broad variability when we talk about internationally that we're seeing with our employers in regards to the accuracy of PCR. So for the most part, there's nothing new in terms of our full understanding of PCR accuracy that is concerning beyond, again, what we saw last year.
Okay, that's all we have time for today. As Karen mentioned earlier, we will post the question and answers on our website. I sent a link to the website earlier in the webinar if you want to look through the chats. Thank you so much, Dr. Harris, and thank you, everyone. We will see you next week.
Excellent. Thanks, everyone. Take care. Stay safe. God bless.